Hi, I'm Dr. Salil Khandwala from Advanced Urogynecology of Michigan, and today we shall be talking about bladder pain syndrome. So first, let's talk about what is it and how common is this condition. So we'll break it up into the definition, how common it is, what is the anatomy, why does this condition happen, what are the patient's presenting complaints, how do we make the diagnosis, and finally, the management. So let's talk about the initial part first, and then we'll talk about the management separately. So what is it? It's a chronic pelvic pain, pressure, or discomfort perceived to be related to the urinary bladder and one other urinary symptoms such as increased daytime or nighttime frequency in the absence of a bladder infection or other obvious pathology such as a stone. The large American study by Conkle et al. Found the prevalence rate to be almost 2.5 to 7%. So 7 out of 100 women could be having this condition. It's between 2 and 5 times more common in women than in men. So what is the typical anatomy and what happens? So again, these are the two kidneys right here, which are in the upper back, and they filter the blood, produce the urine, which is then brought down by these two tubes, one from each kidney, into the bladder. And when they come to the bladder, it opens up through these two little openings, and then the bladder then acts as a storage, just like this. So the urine is stored in the bladder, and this is by the nervous system controlling it. Only when you're ready to urinate, that's when the urethra opens up and the urine comes out like that. So that's the classic function of the bladder and the urethra governed by the nervous system. This is the side view of the human female pelvic organs. This is the front, back, top, bottom. You have the pubic bone in the front. This is the urinary bladder. This is the urethra that brings the urine to the outside. Vagina, uterus on top, rectum at the back. Now, typically the A nerve fibers or A delta, they carry the sensation of pressure and touch. So as the bladder is getting filled up, it'll give you the sensation of fullness. Whereas these unmyelinated C fibers, they carry the sensation of pain and temperature. So in the bladder, it's more of urgency and discomfort as the bladder gets distended. So the C fibers become active. And if the neurotransmitters start stimulating the C fibers, it can produce bladder pain syndrome symptoms. So it's more of that C fiber activation that results in the symptoms. One theory also proposed is that there is a layer inside of the urothelium of the bladder lining called the GAG layer, the glucose aminoglycans layer. And if this layer is cracked or broken, that can result in, so this is the layer again, I was talking about the GAG layer, and then you have the urothelium. So this is a layer which has to be intact. And this is the layer which has no gap junctions, it's very tight. These are the nerves below that, you see right here. So the nerves are below, you have this barrier, and beyond that is the urine. Now, so you can see these are the urine solutes. You have this nice little intact GAG layer, and these are the nerves. So this layer insulates it and protects these guys from coming through. But if there is a break in this GAG layer, you see there is no GAG layer here. So if there is a damage, these guys can come in, irritate these nerves, and create urgency and discomfort. So the main presenting symptoms on the bladder are frequency, urgency, pain if you're holding for too long. So these patients don't have urine leakage. That's a big difference. So what they have is, if I'm holding my bladder and if it takes time and I'm holding more, it will cause me more pressure and discomfort, and that is why I need to go. It is not that I will have leakage. There is also vaginal symptoms such as pain during intercourse at entry at the vaginal opening and also with deep penetration. Sometimes bowel complaints of constipation or diarrhea alternating, such as history of irritable bowel syndrome, very, very common with bladder pain syndrome. Then there is pelvic pressure, heaviness, pelvic pain, a heaviness structure where patients feel that they may have a flare-up of endometriosis, or even something as though it's falling down and they may have a sensation of a vaginal bulging. So what we give them is a special questionnaire, and that's called the PUF questionnaire. And that goes over the frequency, how many times you're going to the bathroom, is there any pain associated with this, and do you have urgency to urinate? Then we come up with a score, and based upon the symptom score and the bother score, and then the total score. Bladder pain syndrome really affects the quality of life of a patient tremendously. She's sometimes literally living in the bathroom. I have some patients who are going to the bathroom every hour or more frequently than every hour, day or night. So they're literally living in the bathroom. And if she does not go there, then she'll have severe pain and discomfort. Like one of my patients told me, she goes to the bathroom, she pees, she cannot go back to bed. She has to sit down on a chair, wait for some time, and go back again. She'll trickle a little bit. Nothing much will come out, but only then does she get that little bit of relief. But then again, in an hour, she's up. Pain and pelvic pressure is very common. Sexual function, of course, is affected because of the pain. And then there is perception of urine leakage because of a very sensitive vaginal opening. So clearly the impact on quality of life is significant on household chores, physical activities where the bladder is bothersome, going to a movie, you cannot sit through a movie because of this frequency. Social activities is the same thing and leads to tremendous frustration. When we examine the patients, you touch it with a soft Q-tip just at the vaginal opening and she's literally jumping off. And that's called vulvodynia. Then a slight palpation of the bladder, finger in just touching the bladder right here causes pain, and that's bladder tenderness. There's no pain at the top, there's no pain at the back, but there's pain here. Sometimes the pelvic muscles also may be in a spasm because they're anticipating pain, so the muscles become very tight. Now let us see how we can diagnose this and what tests do we need. So first of all, we want to make sure that this is not an infection. So we get a urine analysis, a urine culture, a urine cytology may be sent if there is blood or a family history of bladder cancer. But bladder pain syndrome is mainly a diagnosis made upon clinical findings. I may look inside the bladder also and make sure the bladder looks all right. That could be one of the tests. And a 24-hour bladder voiding diaries. Now, this diary will show decreased bladder compliance. So typical normal bladder volumes, our first sensation is about 150 ml, fullness is 350 ml, and a maximum bladder volume is about 500 to 550. In BPS, these volumes are very low. So you can see in this patient how many times she's going to the bathroom, and look at her volumes. They're so low, 75, 100, 100, 100, 150, very, very low volumes. And she's having some tea that needs to be modified. We've got to get rid of, especially if it has caffeine in it, because that can irritate the bladder even more. And in a 3-day diary, you can see that's almost about 11 times a day she's going, 2 to 3 times at night. So going to the bathroom very frequently, even on the 3-day diary and at night too. So we may do the urodynamic testing, and that is we fill the bladder up, and what this will show us is the bladder will have low compliance. I usually do this when patients are complaining of leakage of urine. They'll show low compliance, first sensation will be low, fullness also will be very low, but the bladder capacity may be high. I mean, she can hold if she's pushed to do so, but she would have gone way, way early. So like the first sensation could be 50, fullness could be 100, and she had already gone at fullness normally, like how that other diary showed. But a bladder capacity, if you really pushed it, it would go up to 300 and she would not be leaking. So there's no urine leakage. She feels the leakage because of that vulvar sensitivity, but she mainly has pain with bladder filling and discomfort, and she is like slightly bending over because of the discomfort. We can look in the bladder, especially if there are some issues going on, such as a history of bladder cancer or blood in the urine or smokers and irritative bladder symptoms. It's good to look and make sure the bladder is normal. Most patients with bladder pain syndrome have a normal bladder. Sometimes you may see glomerulations, like a little bit of redness, almost normal. Like this, here you can see very much redness or glomerulations, and here you can see this white scarring area called Hunner's ulcerations. And these Hunner's ulcerations can also be treated, and I'll show that to you in the next slide. So the bottom line is bladder pain syndrome is a very common condition. It affects women more than men. And the symptoms are almost similar to a bladder infection. So the problem is that it often gets misdiagnosed to be bladder infection. Sometimes because of the pelvic pressure and discomfort, it gets misdiagnosed as endometriosis or ovarian cysts, but it is more of a neuropathic condition. It's something happens to these neurotransmitters, and the pain producing substances irritate the C fibers, and that causes pain. Whether the gag layer breaks down also and it affects the nerves could also be one of the theory, but the history is very important. The voiding diaries are very important. The ruling out of a bladder infection, any stone in the bladder or anything else is important. And finally, the treatment, as you'll see, is overall management with many factors. And I'll talk about that in a few seconds.